This lecture will cover topics relevant to adolescent medicine. We'll start with a discussion about menstrual disorders. Half of menstrual cycles are anovulatory in the first year after menarche, so we'll mostly be providing reassurance within this time frame. If puberty was normal, we'd evaluate for structural problems with a pelvic exam and an ultrasound to evaluate for Mullerian agenesis, imperforate hymen, and transverse vaginal septum. If puberty was abnormal, we would check an FSH. This will help to determine if the etiology is gonadal or central. FSH will be normal or elevated in hypergonadotropic hypogonadism. These would include things like Turner syndrome, androgen insensitivity, and ovarian failure. FSH will be low with hypogonadotropic hypogonadism. These would include things like constitutional delay, anorexia or female athlete triad, GnRH deficiency, Kallmann syndrome, or a CNS tumor. When we're working up hirsutism and concern for female virilization, we would check an LH and FSH, testosterone, DHEAS. If your LH to FSH ratio is greater than 3:1, or if you have an elevated testosterone or DHEAS, that suggests PCOS. We also should rule out pregnancy for menstrual disorders and check a thyroid stimulating hormone, prolactin, and FSH. The diagnosis of abnormal uterine bleeding would meet criteria if a patient has excessive bleeding exceeding a volume of 80 milliliters, if bleeding is more frequent than every 20 days, or if periods of bleeding is associated with anemia. We should assess their blood loss and triage if they need surgery or hospitalization with a CBC. We also should get a pregnancy test, coags, thyroid panel, prolactin, and LH to FSH. You can treat abnormal uterine bleeding with OCPs if the symptoms are mild. A 13-year-old girl has irregular periods. She experienced menarche at age 12 and has her period every 1 to 2 months for 5 to 6 day cycles without cramps. Her last menstrual period was 10 days ago and lasted 5 days. What advice should you give? This is abnormal, so we should check a TSH and prolactin. This is normal, provide reassurance. This is abnormal, check an LH, FSH, and a progesterone challenge. This is abnormal, check coagulation factors, CBC, and platelets. The correct answer is that this is normal and we should provide reassurance. With dysmenorrhea, the differential includes endometriosis, which would present with chronic pelvic pain and dyspareunia. We also think about PID, benign uterine tumors, polyps, fibroids, pregnancy or ectopic pregnancy, and whether the patient has an IUD in place. We can treat dysmenorrhea with NSAIDs, also sometimes disguised as a COX inhibitor to treat the PGEs of dysmenorrhea. Sometimes patients need OCPs for this as well. You can treat PMS syndrome with NSAIDs and fluoxetine. A review on puberty, which was gone into more detail in the endocrinology lecture. We'll talk about breast development. Thelarche is the first sign of puberty in girls, to contrast with boys who have gonadarche as their first sign. SMR1 females show breast papilla elevation only. At SMR2, the whole breast is elevated, and we describe this as a mound now. SMR3 has enlargement of the breast and areola. SMR4 has a projection of the areola and papilla to make the buzzword mound upon mound. SMR5 has the general breast contour of an adult. To work up concerns for galactorrhea, we would check prolactin and TSH. We also should scrutinize their past medical history and medication list. It can be caused from anti-nausea meds, psychiatric medications, OCPs, and we should rule out pregnancy. To work up gynecomastia, we would think about psychiatric medications again, antibiotics, anti-androgens, H2 blockers, blood pressure medications, illicit substances, and other reasons for hormone derangement. We go into hormone derangement a little bit more in the endocrinology lecture. You can treat gynecomastia with tamoxifen for up to 3 months. When evaluating a patient with concern for breast mass, the most common breast mass is a fibroadenoma, which is a unilateral breast mass. Fibrocystic disease is bilateral and is described as generalized cord-like nodularities. Fibrocystic disease fluctuates with menses. You can treat fibrocystic disease with OCPs or Provera during the luteal phase. We should observe these kinds of breast masses through at least one menstrual cycle, but then we're thinking about ultrasound and fine needle aspiration to distinguish solid versus cystic lesions. It's important to note that mammography is less accurate in adolescents. Breast cancers in pediatrics are usually from metastases. These are usually subareolar with associated lymphadenopathy. A review on eating disorders. Weight loss should not exceed 3 pounds per week or 12 pounds in 1 month. You can use the SCOFF validated questionnaire to screen for eating disorders. The definitions for anorexia include a disturbance in body image, a fear of gaining weight, and a lack of recognition of issues with low body weight. Binge eating disorders involves eating rapidly, feeling uncomfortably full, eating large amounts when someone's not hungry, eating alone, and feeling negatively afterwards. Binge eating disorder occurs once a week for 3 months, but it doesn't have the compensatory behavior that we see with bulimia. With bulimia, we see recurrent binge eating, a lack of control, and then compensatory behaviors to try and prevent weight gain. We would define this as bulimia if a patient has these behaviors at least once a week for 3 months. ARFID, or avoidant restrictive food intake disorder, associates with weight loss, failure to achieve weight gain or growth, and nutritional deficiency. These patients often have a dependent on supplements or other enteral feedings. We also would consider ARFID if it's interfering with psychosocial functioning and if patients have a lack of interest in foods based on the sensory characteristics. For eating disorders, we would consider hospital admission criteria for complete refusal to eat, a heart rate less than 50, a blood pressure less than 90/45, syncope, hypokalemia, hypochloremia, esophageal tearing, and cardiac arrhythmias. Some common cardiac arrhythmias with these eating disorders include ST depression and prolonged QT. You can treat bulimia with SSRIs or SNRIs, TCAs, and Vyvanse. When we're refeeding patients with eating disorders, we'd look out for low mag, phos, and potassium. We'd look out for rhabdomyolysis, seizures, and delirium from a thiamine deficiency. You're examining a 15-year-old with a BMI of 16. She has enlarged parotids and dental enamel erosion. She has not had a period in 6 months and reports vomiting with every meal. She eats approximately 600 calories daily. She denies excessive exercise, diuretic, laxative, or diet pill use. What is the next best step? Start an SSRI, add a supplement to increase calories, hospitalize, request that she sees her therapist more often, start seeing her twice a week. The correct answer is to hospitalize this patient. She has anorexia with purging subtype. This wouldn't be diagnosed as bulimia because she's not binging. Now I'll talk about contraception as it relates to teenagers. They often wait 6 to 12 months after starting sexual activity before seeking contraception, but half of teen pregnancies occur in the first 6 months of sexual activity. The LARCs, or long-acting reversible contraceptives, are the progesterone implant and the IUD. If a patient needs emergency contraception, they can consider Plan B or Lanorvistril up to 3 days after unprotected sex to prevent implantation. Ulipristal or ELA can also be considered after 5 days. It's more effective if unprotected sex occurred greater than 48 hours ago and more effective for obese patients as well. If you're using these emergency contraceptives, you should delay restarting your progesterone contraceptives, the OCPs, for at least 5 days. The contraindications for OCPs, patches, and vaginal rings include pregnancy until a patient is 3 weeks postpartum, breastfeeding, liver disease, and breast cancer. OCPs, patches, and vaginal rings are associated with increased risk for thrombosis, migraines with auras, high blood pressure, and they interact with rifampin. Smoking is not considered a contraindication to use these birth control methods in teenagers. Women need pap smears starting at age 21 and occurring every 3 years. You should avoid pap smears for patients that have suspected STIs or if they're menstruating because of the risk for false positives. If someone has a diagnosis of atypical squamous cells of undetermined significance or ASCUS on their pap smear, you'd repeat that pap smear in 1 year, and then if you get that same diagnosis, then you'd consider a colposcopy. This slide gives a rapid overview of substances that adolescents might use and some of the physiologic effects that you might see. So K2 is synthetic cannabinoids. It's also called spice. It causes euphoria, anxiety, agitation, paranoia, tachycardia, nausea, and vomiting. Marijuana can cause galactorrhea. Cocaine is associated with tachycardia, hypertension, vasoconstriction, arrhythmias, hyperreflexia, and rhabdomyolysis. Amphetamines are associated with aggression, anxiety, paranoia, tachycardia, rhabdomyolysis, MI, stroke, and arrhythmia. Bath salts are similar to amphetamines. They cause agitation, nystagmus, itching, rash, vomiting, and paranoia. We would treat these symptoms with activated charcoal, benzodiazepines, and naloxone. Benzodiazepines can cause drowsiness, dizziness, aggression, respiratory depression, hallucination, and hypotension. The antidote for benzodiazepines is flumazenil. MDMA can cause hallucinations, seizures, teeth grinding or bruxism, hyperthermia, and sweating. This is ecstasy. PCP can cause nystagmus, hypertension, hypersalivation, fever, seizure, coma, hallucinations, and disinhibitions. LSD causes hallucinations, synesthesia, hyperthermia, piloerection, dilated pupils, lacrimation, hyperreflexia, hypertension, tachycardia, and seizure. And then finally, dextromethorphan can cause euphoria, hallucinations, tachycardia, and hypertension. And dextromethorphan may come up positive on your UDS as PCP as a false positive. You're performing a sports physical for a 12-year-old male. His mom is concerned about a swelling on his left chest. She's concerned about a cyst or lipoma. His development has been normal. His testicles are 3 centimeters in the longest diameter. He has begun to have penile lengthening, and he has only a few curly pubic hairs at the base of his penis. On exam, there is nipple and areolar elevation with a disc of firm tissue underneath. What further counseling and evaluation is best? Order LH, FSH, estrogen, beta-HCG, prolactin, and testosterone. Provide reassurance and routine follow-up. Check a TSH, prolactin, and UDS, or order an ultrasound. The correct answer is to provide reassurance and routine follow-up. A girl was brought in by her mother because she appeared hyper and anxious. She was speaking quickly and was irritable. She told her mother she is just anxious about her homework, but then divulged that her friend gave her Adderall. What presentation is most consistent with this ingestion? Mildly elevated blood pressure, normal heart rate, pupil dilation, and vertical nystagmus. Mildly elevated blood pressure and heart rate, conjunctival injection. Mildly elevated blood pressure and heart rate, pupil dilation, and a fine tremor. Mildly elevated blood pressure and heart rate, sweating, and ataxia. The correct answer for Adderall is that patients will have a fine tremor, pupil dilation, and mildly elevated blood pressure and heart rate. A 17-year-old with bipolar depression is stable on lithium and Lamictal. She wants to start birth control and has a BMI of 30. Which of the following is not an accurate statement? LARCs, the IUD implant, are the most effective methods and do not require her to change her medications. OCPs can be considered, but she should use condoms because Lamictal will lower the effectiveness of OCPs. Depo-Provera is also very effective with no change in medication needed. Or condoms and backup emergency contraception is acceptable. Ulipristal should be prescribed rather than levonorgestrel. The correct answer is that the IUD implant, or LARCs, are the most effective methods and do not require her to change her medications. Answer choice B has it reversed. It said that OCPs would be considered, but Lamictal will lower the effectiveness of the OCPs. Her Lamictal would actually have to be increased because the OCPs would lower the effectiveness of the Lamictal. You're seeing a 15-year-old boy in your clinic. He previously gained weight and his BMI was 20.5. He's worried about being teased in school and started exercising and dieting. His tennis coach told him to decrease carbs and fats. His heart rate is 45, blood pressure is 93/58, and his BMI is now 17 after losing 20 pounds in 2 months. His EKG shows sinus bradycardia. Orthostatics show a blood pressure of 85/54 with a heart rate of 38 when lying down. When standing, his blood pressure is 82/47 and his heart rate is 75. What is the next best step? See a nutritionist weekly and start seeing a psychologist, evaluate for hospital admission, start supplements for weight gain, attain a CBC, CMP, calcium, mag, and phos, and send to the ED if abnormal. The correct answer is that he should be evaluated for hospital admission. He meets criteria for admission with his heart rate less than 50, as well as his blood pressure less than 90/50. You're doing a routine physical for a 16-year-old girl and she asks you about her irregular periods. She had menarche at age 12 and has periods every 2 to 3 months for 5 days. She was treated with isotretinoin last year for acne and is not sexually active. What labs or imaging are inconsistent with PCOS? Multiple small cysts on pelvic ultrasound, elevated free testosterone, insulin resistance and an elevated A1C, or an elevated 17-hydroxyprogesterone. The correct answer is the elevated 17-hydroxyprogesterone because this goes along with the diagnosis of CAH. Which statement about female pubertal development is false? Menarche occurs in most U.S. teens between 11 and 14.5 years. Menarche occurs on average 4 years after breast development. The majority of growth in girls is completed before menarche. Up to 50% of menstrual cycles are anovulatory in the first year after menarche. The correct answer, looking for the false answer, is that menarche occurs on average 4 years after breast development. The time delay is actually closer to 2 years between breast development and menarche. Still within the adolescent medicine topics, we'll discuss STIs in more detail. Teenagers are particularly vulnerable to STIs because of some psychosocial factors predominantly. Their feeling of invincibility and other behavioral factors contributes definitely, and then their lack of healthcare access or lack of knowledge of healthcare access. Physiologically, adolescent females have cervical ectopy, so that increases their vulnerability for STIs as well. You may be tested on the fact that all 50 states allow minors to consent for STI testing, but many states require disclosure to parents sort of broadly if physicians deem it in the minor's best interest. We'll start with an overview of different STI differentials by the presenting symptom, and then we'll talk about the STI constellations in detail later. If a patient presents with discharge, you think about gonorrhea. This discharge would be purulent for gonorrhea. You think about chlamydia, which can have a purulent or mucoid discharge. Trichomonas has a frothy yellow or green discharge. Bacterial vaginosis has a thin or described as white-gray discharge. And then candidiasis has a white and clumpy discharge. If a patient presents with painful ulcers, you think about HSV, chancroid, or Haemophilus ducrei. You think about donovanosis or granuloma inguinal. If a patient presents with a painless ulcer, then you think about syphilis or LGV chlamydia. If a patient presents with growths, you think about HPV and syphilis. Other STDs that we'll talk about are HIV, scabies, pediculosis pubis, and molluscum. Most STIs are asymptomatic, so screening is important. We annually screen for gonorrhea and chlamydia using urethral or vaginal swabs. As needed, we could check a rectal or pharyngeal swab based on the patient's history. We do the urine NAAT for males, and we prefer the vaginal swab NAAT for females, but we can get a urine for them if they're asymptomatic. We would check a gram stain for gonorrhea in symptomatic men. We use a urethral swab for this. We would see PMNs with gram-negative intracellular diplococci. Trichomonas is screened in high-risk females only. The NAAT is more sensitive than the wet mount for trichomonas. We screen for HIV in patients older than 13, and we screen for syphilis in high-risk patients as needed. The syphilis screening starts with a non-treponemal titer and then is confirmed with the treponemal test. The goal for management is a 4-fold decrease in the non-treponemal titer, so we would follow this over time. We do not do asymptomatic screening for HPV or HSV. A 17-year-old male reports a recent onset of sexual activity with his girlfriend. He hasn't used condoms. He has no GU symptoms and wants to know if his girlfriend should be tested, but she won't go to a physician because she doesn't want a vaginal exam. What advice would you give? If his partner has vaginal discharge, then a urine specimen NAAT test would be the most sensitive test. If one partner tests negative in a monogamous relationship, the other partner doesn't need to be tested. If his partner is asymptomatic, she can give a urine specimen for testing. If the patient had symptoms, his partner would need a vaginal exam. The correct answer is that if his partner is asymptomatic, she can give a urine specimen for testing. A 17-year-old female has thin, white, malodorous discharge for a few weeks. She has no pruritus. She has no UTI symptoms, abdominal pain, or fever. She denies oral or anal sex or douching. She's sexually active with inconsistent condom use. She has a history of chlamydia last year. So for this patient, we think about the discharge differential, which we talked about early on in this lecture. We think about candida, bacterial vaginosis, trichomonas, mucopurulent cervicitis from mycoplasma, gonorrhea, or chlamydia, irritant or allergic etiologies, normal physiologic discharge, a foreign body, and HSV or herpes. We'd evaluate this patient with a GU exam. We could get a swab involving a wet mount, KOH, gonorrhea, chlamydia, NAAT, a syphilis or HIV, and then a bimanual exam to triage. We'll start with bacterial vaginosis or BV, which is caused by Gardnerella. We use Amsel's criteria and need 3 out of 4 of these criteria to diagnose this. These are thin white discharge, clue cells, which you can see on the left, a fishy smelling KOH test, and a vaginal pH of greater than 4.5. The gold standard for diagnosis is a gram stain, but this is less practical. Once you diagnose BV, you would treat with Flagyl or metronidazole 500 milligrams orally twice daily for 7 days, or you can use intravaginal Flagyl and clindamycin. Oral Flagyl can cause a metallic taste and nausea, but there's no longer evidence that it actually causes a disulfiram-like reaction when consuming alcohol. A 15-year-old female has 1 week of thick white vaginal discharge, itching, and burning. She denies ever having sex. Her last menstrual period was 2 weeks earlier, and she finished ibuprofen for cramping. She also recently finished antibiotics for pneumonia. You should initiate all of the following workup except NAAT of a vaginal swab for gonorrhea and chlamydia, deferring the workup until after her next menses, a GU and speculum exam, wet mount or KOH, urine pregnancy test. The correct answer for what you should not consider in your workup is to defer the workup until after the next menses. Next, we'll talk about vulvovaginal candidiasis. This is caused by Candida albicans. Candidiasis is not considered a sexually transmitted infection. We see it associated with antibiotics use, estrogen exposure, especially pregnant women, and then patients with diabetes. The discharge is described as thick, white, clumpy, or curdy. Patients often report pruritus, fissures, and erythema of the area, and they often have dysuria and dyspareunia as well. On your KOH, you'll see yeast buds with pseudohyphae. You might check a culture, and there's POCTs, point of care swabs as well that you can do for Candida. You would treat this with oral fluconazole as a single dose, or you can use the OTC's miconazole intravaginally. They have 1, 3, and 7-day preparations for this. Trichomonas is a sexually transmitted protozoa. It's associated with HIV and preterm birth. Trichomonas is not considered reportable, but you should treat partners of patients who are diagnosed with trichomonas. It's usually asymptomatic, but patients can have a profuse, malodorous, yellow-green, frothy discharge, dysuria, and we often see the buzzword strawberry cervix associated with trichomonas. On a wet mount, you'll see white blood cells and trichomonads. These patients need Flagyl orally twice daily for a week for women, and then you just need 1 dose orally of 2 grams for men. It's important that patients who are diagnosed with trichomonas abstain from sex for 7 days after their treatment is finished, and they should be rescreened at the 3-month mark to make sure that this infection's been eradicated. An 18-year-old male has 4 days of dysuria and slight discharge. He thinks his girlfriend had another partner. He's not using condoms, but his girlfriend used Plan B. He doesn't have any history of STIs. He received the HPV vaccine. We would diagnose this patient with urethritis by confirming his discharge on exam. We might check a gram stain of the discharge, and if that showed 2 or more white blood cells per field, then we could diagnose urethritis. And then if we check a urine and he has leukocytes or greater than 10 white blood cells per field, then we would also diagnose urethritis. We would check an NAAT for gonorrhea, chlamydia, and give a presumptive prescription. Usually, male urethritis is caused by chlamydia. This can progress to epididymitis and prostatitis. Some more details about chlamydia. Patients with chlamydia are usually asymptomatic. They can have a 7 to 21 day incubation period. Some buzzwords: chlamydia is often described with intracytoplasmic inclusions because it's an intracellular anaerobe. You would diagnose chlamydia with a PCR. Males present frequently with scant mucopurulent urethral discharge. They also will present with dysuria and frequency. Males with chlamydia can progress to having epididymitis and prostatitis. For female patients, they'll present with dysuria, frequency, vaginal discharge, abnormal vaginal bleeding, cervicitis, endocervical mucoid discharge, and a friable cervix. Female patients with chlamydia can progress to having tubo-ovarian abscesses, PID, Bartholinitis, and Fitzhugh-Curtis syndrome. Males and females can progress to have conjunctivitis, pharyngitis, proctitis, reactive arthritis, which is associated with HLA-B27, and for men, they can have a circumant balanitis rash. Chlamydia can also cause LGV, which features small painless papules or ulcers that progress to a tender unilateral lymph node and groove sign, and we associate LGV with tropical areas. Neonatal chlamydia is associated with pneumonia, which features a staccato cough, and neonates can also get chlamydial conjunctivitis. We think about this happening in neonates that are less than 1 month old, and we would treat them with oral erythromycin. For other cases in the adolescents and adults that we talked about, we would treat with doxycycline for 7 days. If patients are allergic to doxycycline for chlamydia, we can use levofloxacin or azithromycin once. A 17-year-old has 1 day of pus on his boxers, dysuria, and urinary frequency. He reports a new sexual partner without protection, and he has a history of chlamydia 2 years ago. This patient has gonorrhea. Gonorrhea can cause pharyngitis, conjunctivitis, and proctitis. With disseminated gonorrhea, we'll see a rash. We should culture those pustules to help confirm this diagnosis. Disseminated gonorrhea is also associated with arthralgias, tenosynovitis, hepatitis, endocarditis, myocarditis, and meningitis. Some risk factors for gonorrhea infection include complement deficiency, females are at higher risk, pregnancy, and when a patient is within 7 days of her menses. Gonorrhea looks like a gram-negative diplococci. It becomes intracellular once it's disseminated. You would treat gonorrhea with ceftriaxone 1 dose intramuscularly. If you're not sure if a patient has chlamydia or not, you would add doxycycline presumptively for a 1-week course. If a patient is allergic to that 1 dose of ceftriaxone intramuscularly, you could use gentamicin with azithromycin. Epididymitis looks like an inflamed, swollen scrotum. Some patients will have urethral discharge, dysuria and frequency, nausea, vomiting, and fever. The most common causes for epididymitis in sexually active young adult males is gonorrhea and chlamydia, which can be a manifestation of PID or pelvic inflammatory disease. Mucopurulent vaginal discharge, right upper quadrant pain, abnormal vaginal bleeding, dyspareunia, or all of the above. The correct answer is all of the above. PID is essentially an ascending polymicrobial infection. The minimum diagnostic criteria for a patient with pelvic or lower abdominal pain involves concurrent either cervical motion tenderness, uterine tenderness, or adnexal tenderness. The definitive diagnosis might be made with laparoscopy, biopsy, ultrasound, or MRI. You essentially treat PID for gonorrhea, chlamydia, and for intra-abdominal infection. So you treat with ceftriaxone once for gonorrhea, doxycycline for 14 days for the chlamydia, and then Flagyl for 14 days for the abdominal infection. Hospitalization criteria for PID include pregnancy, high fever, intractable vomiting, and if a patient has failed outpatient therapy. PID can progress to tubo-ovarian abscess, so if a patient is failing antibiotics, you should consider an ultrasound to rule this out. It can also progress to Fitzhugh-Curtis syndrome, which is a type of perihepatitis. Fitzhugh-Curtis patients will present with sudden right upper quadrant pain, but their LFTs will be normal. PID can also progress to adhesions, infertility, and ectopic pregnancy. A 19-year-old male has a painless lesion on his penis. He's had gonorrhea and chlamydia before. He's struggling with substance abuse and with incarceration. This vignette suggests a patient with syphilis or treponema pallidum, which is a spirochete. Patients with syphilis often present with a painless chancre, which is a painless papule that progresses to a punched out ulcer. They also may have regional lymphadenopathy. Systemic symptoms of syphilis include a maculopapular rash on the palms and soles, condyloma lata, which looks like gray papules on the genitourinary region, a flu-like syndrome, and lymphadenopathy. Patients with early congenital syphilis will show skeletal abnormalities, hepatosplenomegaly, rhinitis, also called the syphilis snuffles, a rash, lymphadenopathy, jaundice, and the Hutchinson's triad. Late congenital syphilis patients will have abnormal face and palate structure and dental deformities. How is most genital HSV2 transmitted? During a prodrome of a recurrent episode, through skin-to-skin contact of an ulcer and a primary infection, during asymptomatic viral shedding, through skin-to-skin contact of an ulcer and a recurrent infection, during rebound of viral activation following discontinuation of suppressive therapy. The correct answer is that genital HSV2 is most often transmitted during asymptomatic viral shedding. A 19-year-old male presents with 2 days of painful sores on his penis, dysuria, fever, and headache. He has no history of cold sores. He had a new sexual partner 1 week ago with oral genital contact. He has a history of chlamydia and penile warts. This patient has genital herpes or HSV. The primary infection with genital herpes is usually asymptomatic, but then patients can have multiple small lesions described as clustered vesicles on an erythematous base. These can coalesce to cause a painful, shallow ulceration and crusting. These patients can have tender lymphadenopathy as well. The transmission is through direct contact, usually with asymptomatic shedding, and HSV2 is associated with HIV infections. Neonates who contract HSV can have infection of the skin, eye, and mouth, and they can progress to meningeal encephalitis. You would diagnose HSV with a PCR for HSV DNA and a viral culture. You treat with oral acyclovir. You give this IV for infants. You can also treat with valacyclovir or famciclovir. If it's the first infection, you would treat for 7 to 10 days, and if it's a recurrent infection, you treat for 1 to 5 days. Once a patient's been treated, you should treat them with suppressive treatment as well for maintenance, for decreasing the recurrences, decreasing transmission, and shedding. The following are true about condyloma acuminatum, except it is a viral infection. Despite treatment, this can recur. Patients should be tested for other STIs. There's a high risk of malignant change in these lesions. Even if warts are removed, the patient may still be infected and able to transmit the virus. The correct answer is that condyloma acuminatum does not have a high risk of malignant change. Condyloma acuminata is caused by HPV or venereal warts. Patients usually transmit HPV when they're asymptomatic, skin-to-skin contact. The most common STD is HPV. The warts are described as flat, papular, pedunculated, rough, and flesh-colored. We describe them as verruca vulgaris unless they're in the GU region, and then we call them condyloma acuminata. These warts typically appear 2 to 3 months after infection, and they have a variable progression. The risk is by the strain, so the low-risk HPV strains are 6 and 11, and then the higher-risk HPV strains are the higher numbers, starting with 16, 18, 31, 33, 45, 52, and 58. These have progression to cervical cancers. We treat with imiquimod, podophylox, Cinacatchin topicals, and in the physician's office, especially for verruca vulgaris, we use salicylic acid, cryotherapy, or surgical resection. If a child has venereal warts and they're younger than 3, then this could be prenatal acquired, but if it's after 3 years old, then we would consider child abuse. An 18-year-old female tests gonorrhea positive and chlamydia negative on screening urine NAAT. She's asymptomatic. What should you do next? Treat with ceftriaxone 250 milligrams once. Treat with azithromycin 1 gram orally once. Treat with ceftriaxone 500 milligrams once and examine the patient to rule out PID. Gram stain to make a definitive diagnosis, or repeat NAAT on a vaginal swab. The correct answer is that she should be treated with ceftriaxone 500 milligrams IM once for her gonorrhea, and she should be examined to rule out PID. A sexually active female presents to a school-based health center requesting testing for sexually transmitted infections. She's asymptomatic but concerned because she had sex for the first time and did not use a condom. She's on OCPs for acne treatment. You order NAAT for chlamydia and gonorrhea. Which of the following statements is true regarding NAAT testing? The specimen of choice for diagnosing urogenital chlamydia and gonorrhea is a first-time urine for males and a vaginal swab for females. The FDA has approved NAAT testing on male and female urine samples, clinician-collected endocervical, vaginal, and male urethral samples, male and female rectal and oropharyngeal samples, and self-collected vaginal swabs if obtained in a clinical setting, as well as testing on liquid-based cytology testing for pap smears. NAATs performed on self-collected vaginal swab specimens are equivalent in sensitivity and specificity to those collected by a clinician, or all of the above. The correct answer is all of the above. This is the last question. A 19-year-old male is diagnosed with a symptomatic urogenital chlamydia infection and treated with doxycycline 100 mg PO BID for 7 days. Using expedited partner therapy, or EPT, the patient is given a prescription for the same treatment for his girlfriend. Which of the following would you advise? No follow-up is needed as long as the patient and partner are compliant with the treatment. No follow-up is needed as long as the patient and his partner are abstinent until completion of his treatment. No follow-up is needed as long as the patient's symptoms resolve. Follow up and obtain an NAAT test 2 weeks later. Follow up and obtain an NAAT test 3 months later. The correct answer is to follow up and obtain an NAAT test 3 months later. We wait for 3 months to pass to avoid a false positive, but we would test earlier for test of cures in pregnant or symptomatic patients. And that is the end of this lecture.